good afternoon, and thank you for joining us today. Today is actually the first part of a two-part session, a webinar series, which we're in INNEG doing this month, focusing on neuropsychiatric and neuropsychological evidence within the expert witness and medico-legal world. Interestingly, from an INNEG perspective, it's one of the questions which solicitors ask a lot of us, and are surprised to hear that we can support solicitors searching for both neuropsychiatric, neuropsychological, as well as obviously regular psychiatry and psychological evidence, be it child, adult, or any of the more unusual subdisciplines, including forensic. You're welcome to go onto our website where you will see all of the different areas of experts that we support. And obviously, if you have a need, I would recommend you do so. But onto the main event today, I'm really pleased to welcome our speaker, Dr. Bruno Silva. Bruno is a consultant neuropsychiatrist with a number of years of medico-legal experience. He's regularly instructed in both personal injury and clinical negligence claims, and obviously, particularly in cases involving functional, neurological, cognitive symptoms, fatigue, and obviously neuropsychiatric interests. So without further ado, I would like to introduce Bruno to present to you today, and to advise that he will field any questions that you have following the event. So please feel free to put your questions in the box at the top in either the chat or the Q&A function. And with that, over to you, Bruno. You're just on mute at the moment, but welcome, and over to you.
Fantastic. Thank you very much, Leo, for the introduction. It's a pleasure to be here, and thank you for the invitation to talk about this subject, which is quite dear to me. So I always welcome any opportunity to talk to people about functional neurological disorder. So sorry, I'm just trying to progress with the slides here. So today we are going to be looking at a few to try and clarify a few ideas and a few concepts within the field of functional symptoms. So we will start by talking about what are functional symptoms, how are they diagnosed in clinical practice, and then we will talk about the very tricky issues of causation and symptom validity, which are of course quite important in the medical legal context. Then I will tell you a bit about treatment and prognosis for these conditions, and I will present a brief case from my own medical legal practice, which I believe has some important take-home messages that will allow us to better understand how these issues work in practice. So, what are functional symptoms? The first thing that we need to understand about functional symptoms is that they are real and involuntary. So when I say that they are real, this means that the patient is not voluntarily making them up. So these are not symptoms that are put on, exaggerated, or malingered in any way. The symptoms are real, and from the patient's perspective, they are indistinguishable from symptoms that you would get from other injuries. So from the patient's perspective, they don't know that they are suffering from functional symptoms. They know that they are suffering from symptoms that feel just as real as any other symptom. And the fact that they are involuntary means, again, that they arise completely outside from the control or the agency of the patient. The second thing to understand about these symptoms is that they are internally inconsistent. And what this means is that within the same patient and within the same observation, you will observe these symptoms fluctuating, either in an on and off fashion, where they appear and they disappear. They can fluctuate in severity, but despite this internal inconsistency, they are still patterned. There is an underlying pattern to them that is longitudinal. And if you observe this patient for a long enough time, and if you collect a careful history of the symptoms and the clinical presentation, you will find this pattern. They are symptoms that can be very influenced by attention, expectation, and the perception of threat. What that means is that sometimes when observing a patient, if they are focusing their attention on the symptom will become worse and will become more severe. If they are distracted, then the symptom may reduce in severity or may even temporarily disappear. Expectation means that sometimes when the patient is actively thinking about the symptom, or when they are in a situation where they perceive a threat, or when they are under stress, the symptoms will also exacerbate in severity, and they may have periods where they are in a more relaxed environment, where they feel more comfortable or less threatened, and then the symptoms will reduce in severity. They often fluctuate over time, and this is a key point that often causes a lot of confusion, is that investigations that you would normally request to look at those symptoms are often normal or non-explanatory. We will see later on that they may not be normal, but it's more about there is a certain symptom and you do an investigation where you expect to find something, and then the investigation turns out to be reported as normal. And that creates this inconsistency between the symptom that you are observing and what you would expect to see in investigations, for example, brain scans or EEGs or other sorts of medical investigations. Now, before we get on to the actual clinical side of things, and I give you a few examples of functional symptoms and how we go about diagnosing them, I think it's important to talk about nomenclature, because these symptoms have been known by many names, and some of them are still used today, even though they have been superseded by more current nomenclature. You will still see people talk about conversive symptoms or conversion disorder, psychogenic, medically unexplained. So these terms are still used both in clinical practice and in the medical legal field. But I think it's important for us to know what the correct nomenclature is, because these names may create unnecessary confusion. So the reason why we call them functional is very simple. In medicine, whenever you talk about functional, you are talking about performance. There is a certain system, for example, the nervous system, the brain, but it can also be the lungs, can be the heart, can be any other organ. There is a system that is supposed to do something, and you are observing a symptom. That means that system is not working properly. That is function. When we talk about structural damage, we are talking about physical damage, loss of tissue, or physical changes to a tissue or an organ. So if you think about the brain, the classic structural damage would be someone who suffers a traumatic brain injury, and then you do a brain scan and you see bleeding, or you see destruction of the cortex, you see actual evidence of physical damage that tissue suffered. When we say that something is functional, it means that that organ is not working properly, but that may occur in the absence of any structural damage, meaning that if you look at the physical appearance of that organ, it will appear to be normal. Now, this, again, causes a lot of misunderstandings in the field of functional neurological disorders, but this is nothing new in medicine, and it's not controversial at all in other fields of medicine. For example, migraines. They are relatively non-controversial as symptoms, and it's a very common diagnosis. But if you do a brain scan of someone with severe migraines, the brain scan is absolutely normal. You won't see anything there. You can do an EEG, you can do a bunch of other investigations, and you won't see a thing. But that's not controversial, that someone has migraines. If you think about someone with asthma, especially in the early stages of the illness, they can have severe problems breathing. But if you do a CT scan of the lungs, you won't see anything. But still, the lungs are clearly not functioning properly. Someone with a severe arrhythmia, where their heart rate is out of sync or very fast or very slow, if you do an MRI scan of the heart or an echocardiogram, you may not see anything, any structural changes. The muscle of the heart looks okay, but the function is disturbed. So this is not something new, and it's not something that's controversial in other areas of medicine. One way to think about this, and this is an analogy that is often used in clinical practice, it's usually very well received by patients, it's the hardware versus software problem analogy. So for example, let's imagine an hypothetical scenario where you are working on your NHS supplied computer and you just spent 20 minutes writing a very long progress note about a patient you just saw. And then you click save and the browser freezes and crashes. And when you restart it, you realize that your progress note is gone forever. Again, completely hypothetical and not something that happens almost every day in NHS practice. Clearly, the computer did not perform as it would be expected. But then if you look at the computer itself, if you open it up, or if you do a scan of the internals of the computer, the hardware will appear to be completely intact. The hard drive, the motherboard, the RAM module, the processor, they are all physically intact. And yet, clearly something did not work as expected. It was a software problem. Even though the hardware that supports the function of the software was absolutely intact, the software still glitched and malfunctioned. In the brain, you can think about the brain as the hardware. So when you do a scan, you are looking at the structural, the physical appearance of the brain. And you can think about the mind, thoughts, cognition, voluntary action as the software that is supported by that hardware. Now, whenever the function of the brain changes, there are two explanations. Either the hardware is malfunctioning and then the software malfunctions as well, or the hardware is intact, but the software is malfunctioning, and then you get symptoms. A quick note about the historical terms, just to tell you where they come from. Hysteria is a very old term that actually originated in ancient Greece, when they thought that these symptoms arose because of problems with the uterus, the womb. Conversion is an inheritance from the time when psychiatry was completely dominated by psychodynamic and Freudian theories like psychoanalysis. This was probably between the 1920s up to the 60s. Mainstream psychiatry was dominated by these ideas, and conversion literally meant, as it was taught back then, that the patients were converting a psychological, an unconscious psychological distress was being converted to a physical symptom, hence the term conversive disorder. Psychogenic is pretty straightforward. It pretty much means that the symptoms arises from psychological conflicts, when, again, this is not true, and it's something that's not been demonstrated in functional neurological disorder. Non-organic is, again, something that is incorrect, because at the end of the day, the mind arises from the brain as well. Just because we don't see it in a scan doesn't mean that it's not malfunctioning. And medically unexplained symptoms is perhaps, in my humble opinion, one of the most unhelpful and uninformative term ever created. And it's just plain wrong, because these symptoms are not medically unexplained. They are explained by functional neurological disorder, which is a medical diagnosis. So, in my opinion, all of these historical terms are best avoided, such as not to create misconceptions or any misunderstandings. Now, again, just to reiterate what functional symptoms are not. So it does not mean that just because the symptoms are functional in nature that the patient can stop them at any time at will. They cannot. They are involuntary symptoms. It does not imply in any way exaggeration. Exaggeration implies voluntary intent, which is not the case in FND, and we will talk later on about how we make that distinction clinically. It does not mean medically unexplained. Again, I really hate this term, so I actually put it here twice. It does not mean that nothing is wrong, and this, as you can imagine, from the patient's perspective, is extremely frustrating and distressing. When you are feeling real symptoms that often have a very severe impact on your day-to-day functioning, you go to your doctor, you do a bunch of tests, only to be told at the end, rest assured, there is nothing wrong with you, the investigations are all normal. And then clearly you are still feeling quite ill and you have very distressing symptoms. So this is a very unhelpful term that should just not be used. And it does not mean that it's all psychological, because in many, many cases, there is absolutely no comorbid psychiatric diagnosis. There is no anxiety disorder, there is no depression at all, and still people get these symptoms. So it's not a consequence of some sort of psychiatric disturbance that is causing these symptoms. Now, common presentations. What do these symptoms look like when patients suffer from them? So typical symptoms include the motor system, for example, weakness of the arms, weakness of the legs, sometimes even complete paralysis. The patient is unable to move that limb at all. You can have problems with walking, balance issues, tremors, abnormal movements. You can have non-epileptic seizures. So you can have people having episodes that look like seizures, particularly to the lay audience. Sometimes there are certain details of the seizure that the trained eye can detect and, okay, make the assumption that this does not look like an epileptic seizure. But to the untrained eye, they look like any other epileptic seizure, but they are not associated with epileptic discharges in the brain. They are functional in nature. Can be cognitive complaints, which sometimes is referred to as functional cognitive disorder. That is just a subtype of functional neurological disorder that affects cognitive function. And interestingly, and we will talk about this in more detail later on, these symptoms often follow a physical injury. And this is the tricky part. These symptoms are actually very common after people have been involved in a road traffic accident where they have suffered some sort of physical injury that can be to the brain or to the body, can be after a neurological insult, someone who has actually had a stroke, and then they develop symptoms that are not necessarily related to the area of the brain that was affected by the stroke, or critical illness. Someone who has been to intensive care, for example, someone who has been in a coma, someone who has undergone some complex medical procedure. And often these symptoms may appear disproportionate to the severity of the initial injury. And this, again, is a very common issue in the medical legal practice. The patient suffers, for example, a mild brain injury, and then they develop ongoing symptoms that the neurologists have trouble fully ascribing to the traumatic brain injury. And functional mechanisms might be at play there. Now, we have talked about the functional symptoms. Now let's talk about the diagnosis. So again, symptoms are not diagnoses, they are observations or complaints or dysfunction that we observe in the patients or that the patients report themselves, and then we have the diagnosis. So functional symptoms, when they present in a certain way with sufficient severity and cause disability or impairment of function, then they can fulfill criteria for a diagnosis of functional neurological disorder, FND. What does this mean? It means that the patient has one or more symptoms of altered voluntary neurological function. That's usually movement, cognition, speech, etc. And then, and this is quite important, and I will elaborate on this later on, the clinical findings, that what you see when you examine the patient, demonstrate incompatibility between the symptoms and structural neurological disease. So what this means is that the symptom that you are seeing, if it were related to a structural problem like a stroke or a tumor in the brain or a brain injury, you would expect to see the symptom presenting in a certain way that respects the anatomical organization of the brain. Whereas the symptoms look unusual, atypical. Again, to qualify for a diagnosis, the symptoms must cause significant distress or impairment, and they almost always virtually do. And this diagnosis is formally encoded and recognized in most major diagnostic manuals, including the DSM and the ICD. How do we actually diagnose this in clinical practice? And the most important message to take home about the diagnosis of FND is that FND is not, I repeat, it is not a diagnosis of exclusion. We do not diagnose FND because the patient has symptoms. We do investigations. The investigations are negative, and we say, okay, if the tests are negative, then it means it's FND. This is perhaps the biggest misconception about functional symptoms, and this is not at all how the process goes. So how do we actually do it? The diagnosis is clinical. we don't need investigations to diagnose FND. We often carry them out for specific reasons, but the diagnosis does not require investigations. What the diagnosis requires is, first, there are symptoms. Okay, that bit is obvious. But then the symptoms have what we call positive features that point towards a diagnosis of FND. And what I mean by positive features is that you can actually test the patient clinically and you can observe certain characteristics of the symptoms that mean that they are functional in nature. So even before you request any tests, even before you realize that the brain scan is normal, you are already observing characteristics of the symptoms based on the patient's presentation that tell you or that strongly suggest that the symptoms are functional. So you are observing signs that point toward the diagnosis, and that's what we mean by positive findings. We, of course, always collect a very detailed history and a chronology of the symptoms, and I will explain why later on, why it's important to do a very thorough history. You do the examination that actually shows the positive signs, as I was talking about before, and then you argue and you are able to demonstrate, just based on these clinical findings, that there is an incompatibility between the symptom and any supposed structural illness. And that's when you are able to make the diagnosis clinically. Importantly, you don't need to demonstrate that there are psychological stressors causing these symptoms. This used to be the case in the old classifications, especially for what was then called conversive disorder. There was a requirement in the diagnostic manuals that you had to demonstrate a psychological stressor. We have now realized that for many, many patients, there's no psychological stressor, or at least an obvious psychological stressor, and therefore that is no longer a requirement. So again, that idea of psychogenic symptoms, this is all psychological, that's old. That's the old interpretation. We now know that is not the case for everyone. So that's no longer a requirement. And the investigations that you then carry out after you have clinically suspected FND, you may carry out investigations either to rule out a competing diagnosis because you think, okay, this could be FND, but could also be a rare presentation of a certain structural illness. So you carry out the tests to rule out other illnesses, not to confirm FND because the tests are normal, if that makes sense. But interestingly, and this is again when cases often become complex, investigations may be abnormal. There may be something on the scan. What you need to show is that the symptoms you are observing are not fully explained by what you see on the scans. They are either in excess or they do not conform to the anatomical abnormality you saw on the scan. And sometimes you have patients who have both. It's very common, for example, to have patients who have epilepsy, as in true seizures that are caused by epileptiform activity in the brain, but they also have non-epileptic seizures. Some of them are epileptic, some of them are not, and they often coexist. And that's another layer of complexity that these cases often have. Some examples of those positive signs that I was talking about earlier. For example, you are assessing a patient who complains of limb weakness, and you see that there is weakness during testing, but then you use distraction techniques and you observe that the limb may regain function or strength under those circumstances. Or for example, you do a test where you induce someone to use the limb in a way that is not voluntarily controlled, as in you activate automatic systems in the body that trigger that movement, and you observe that the limb is able to carry out that movement when it's automatic, but not when it's under voluntary control. If someone is complaining of a tremor, for example, a tremor that is functional in nature is often improved by distraction techniques again, when you ask the patient to do another task and then you observe the tremor and then it fades away, or it's entrainable. What that means is that if the patient has a tremor in the right hand and then you ask them to tap their left hand at a certain rhythm, the tremor on the right hand will entrain with the rhythm of the tapping and they will sync in synchrony, which is not the case for other types of tremors, or it varies through the examination. The patient may complain of a sensory symptom, for example, like numbness or pins and needles that do not conform to anatomical distributions of the nerves on the skin. Or in the case of cognitive functional disorder, you may have someone who complains of marked memory problems, and when you test them, they may show those problems, but then when you ask them, can you describe what you did yesterday or what you did last week or what happened during the accident, they are able to tell you with very good detail what has happened to them, which is, again, that inconsistency between the symptom and the function. Right. So now that we have diagnosed FND and that we understand how these symptoms present and what they look like, what causes it at the end of the day? I spent quite some time trying to convince you that they are not psychological or psychogenic in origin. So what's the explanation? Where do they come from? Well, the short answer to that is that we haven't found the smoking gun yet. So it's not entirely clear, or there's no single mechanism that has been found so far that fully explains the whole range of functional disorders that we observe. However, there's been quite some research into this, and we know that through research level imaging techniques that are not available in clinical practice. We know that there are altered brain network connectivities, as in the way that the neurons talk to each other and the way that brain networks are organized in the brain can be deranged in FND. We know that patients with FND often have altered attention mechanisms, which explains why when they focus their attention on the symptom gets worse, where it sorts of overrides the automatic mechanisms that a lot of us use to carry out a lot of our neurological functions, like walking and maintaining our balance, for example. They often require automatic functions that we don't think about, but if we pay a lot of attention to it, it actually makes things worse. If you try to think about moving your legs when you are walking, you will probably find that it's much more difficult than just not thinking about it and just walking somewhere thinking about something else. Whenever someone is under stress, the symptoms usually get worse, and that's been proven as well, that when you have heightened threat situations, this changes the way that brain networks function in the brain, and that gives rise to the symptoms. And sometimes, again, this top-down motor or cognitive control means that when you are trying to exercise too much control over things that should be done automatically by your brain, it usually means that you are doing things in a less efficient way, and that can give rise to disturbance and to symptoms. Now, again, none of these mechanisms by itself is necessary or sufficient to explain FND. There is a growing body of evidence in neuroscience supporting that FND actually arises from this dysfunction in these brain networks, but we still haven't found a single unitary explanation that we can offer and say, look, this is what causes every case of FND. But they do support all of these pieces of evidence and all of these research strands. They all support the notion that these symptoms are real, involuntary, and variable. Now, in medico-legal terms, and actually also in clinical terms, in neuropsychiatry and in psychiatry in general, when we are thinking about what causes something, we don't usually think about in direct terms, as in this one thing caused this illness. In neuropsychiatry, causality is often thought in the vulnerability trigger maintaining factor sort of framework. What this means is that whenever someone has a disorder or when someone presents with a symptom, it means that there was probably, or in many cases, there is a pre-existing vulnerability that sort of sets the stage and increases the chances that that person will eventually develop a symptom or a disorder. Then there is a trigger. This is usually an environmental trigger. Something happens to that person that sets off the illness. And then there are maintaining factors which are ongoing and usually mean that the symptoms become chronic or prevent recovery. Now, in the vast majority of cases, all these three are present. And this is true for the whole of neuropsychiatry, psychiatry, but also in other fields of medicine. What this means is that causation is not straightforward. It's not one thing causing one thing. It's usually several things working together to cause that final presentation. Now, this does not mean that we cannot argue for causation in medical legal terms for FND. We actually can. It just means that we need to take all of these things into consideration. What this often means in practice is that as a neuropsychiatrist, I am not always able to say that, yes, the index event, the index injury is the sole responsible factor for this patient's complaints and this patient's symptoms. There's usually other things at play, and that's why I usually do a full and complete history. The claimants are often surprised when I say that, unlike the other experts that have assessed you so far, we will start from the very beginning, actually from before you were born. I want to know about when your mother was pregnant with you. I want to know about what happened when you were born. Were there any complications, any childhood difficulties, any bullying, any trauma? Because all of those things create vulnerabilities, and they may set the stage for later illness. But there is one important thing to remember here. And again, this is another misconception that I often come across, and I get asked this a lot, which is, so that means because you found that pre-existing vulnerability, that means that the illness would have happened in any event, that regardless of, the index injury and in the but-for scenario, this person would have developed a functional neurological disorder because they were already vulnerable and they had pre-existing psychological difficulties. But that's not true at all. Vulnerability does not mean inevitability. In fact, the evidence is very clear, and the published studies and the published literature on this topic, it's very clear to show that, yes, it is true that patients with FND compared to the general population have a higher burden of pre-existing vulnerabilities, for example, a history of trauma or a history of psychological distress. However, the vast majority of people who experience early life trauma, who experience psychological distress, do not go on to develop FND. So it usually requires something else. And that something else, in many instances, is the index event, the index injury. It's the road traffic accident. It's the brain injury. It's the consequences of the clinical negligence that resulted in the prolonged pain or prolonged distress. That those trigger events are often required for the illness to manifest itself. You can have a lot of vulnerabilities, but without the trigger, you may go your entire life without developing FND. And the research shows that's what happens to most people. But under certain circumstances, you go on to develop an illness. And then what happens after the event, all the fallout, all the consequences, sometimes even the litigation process itself, often act as maintaining factors. So often patients develop these functional symptoms, and then they persist for many years after the injury. And you have the neurology experts saying, well, by this time I would have expected the patient to recover fully, but he's still complaining and he's still very disabled. And that seems inconsistent. This doesn't match up with the physical illness. But in reality, what has been happening through all of those years is acting to perpetuate the symptoms. And the litigation process often plays a role in that as well. So when explaining causation in FND, it's not about me being able to say, yes, the index injury is the sole cause of this. I am 100% certain that this would have never happened without the index injury. It's about explaining and demonstrating that this trajectory from vulnerability to illness was significantly and materially impacted by the trigger event, by what happened to this person, and to show that on the balance of probabilities, all things considered, the index event. But if the index event had not happened, then this person would not have developed FND, despite their vulnerabilities and despite their previous history. Another issue that is often can be quite controversial in FND is the notion of symptom validity. And I was very happy to hear that there will be a neuropsychology session as well. because symptom validity testing is something that often is brought up when the neuropsychologist sees a claimant. And what these are, so these tests are usually embedded into neuropsychological tests that test memory, concentration, etc. And they often give a score of what's sometimes called effort or a validity score. Now, the thing about these neuropsychological tests is that just because someone fails a symptom validity test, it does not mean that they are purposefully exaggerating their symptoms. Symptom validity tests do not produce a diagnosis of malingering. They do not prove intent at all. What they show is there was something about the way this person did this test that is unusual. Now, there are several explanations to that. One obvious explanation is, of course, malingering, that someone was voluntarily trying to produce the symptoms. But there are many other explanations as well that can justify not passing a symptom validity test. That can be uneven attention, that can be the stress during the assessment, and those are features that are often present in patients with FND. So it is not uncommon for patients with FND to fail symptom validity tests, but a good neuropsychologist will look at that, will look at the history, and will interpret the results of the symptom validity tests in that context. And it will explain that, this does not necessarily mean that the patient was not putting in effort. It does not mean that they were consciously fabricating the symptoms or exaggerating. This is something that can actually be seen in FND, and it needs to be interpreted in this context. So symptom validity tests, they do not by themselves produce a verdict of malingering versus not malingering. They provide an additional piece of information that can then be interpreted in the overall context. Just because I saw a few cases where there were concerns about the performance in symptom validity testing, but again, good neuropsychological evidence will be able to put that in context. Now, here's a few clues that we use in clinical practice when we try to distinguish between FND and malingering. In FND, even though there are those internal inconsistencies that we talked about earlier, there is a longitudinal consistency. These patients' symptoms tend to be quite predictable in time, and they tend to be quite constant. Whereas in malingering, the presentation usually changes to match expectations. A patient who malingers, for example, may present in a given day, and the symptom looks in a certain way. And then you discuss with the patient that, okay, so in your case, I would have expected to see this and that. And then the next time they come around, or the next expert that they see, the symptom will look like that. So there is a certain expectation that is created. Oh, in your case, if you had this illness, I would have expected to see this. And the next time the malingerer comes around, they are usually presenting exactly like that. This usually does not happen in FND. The presentation is consistent across observations, across different experts, and across different contexts. If you look at the NHS records, they will show the same as the experts. The inconsistency in FND is more patterned, whereas in malingering, it's consistently below expectation or implausible. Again, in FND, symptoms fluctuate with attention, context, or distraction, whereas in malingering, they are always strategically worse when the patient is being tested. Real-life functioning is often very much affected in FND, whereas in malingering, there is a discrepancy between real-world functioning and the symptoms. And patients with FND often have no problem engaging with assessments and rehabilitation and treatments. Patients who are malingering often avoid assessment and treatment. When confronted with the question of symptom validity in FND, it's important to reiterate those aspects that I was talking about when these patients do this sort of testing in neuropsychological assessment. Always interpret them in the context, and do not assume that just because a patient fails a symptom validity test, that means that they are exaggerating or that they are malingering. So how do we treat patients with FND? Well, this is another problem that we often see in clinical practice and in the medical legal practice as well. The problem is that even though the symptoms look like symptoms that people with structural brain disorders have, for example, paralysis, difficulty walking, cognitive symptoms, the treatment is very different. But what often happens, unfortunately, is that patients with functional neurological symptoms are offered rehabilitation and treatment just like they would be if they had a stroke or a brain injury or something else that caused those symptoms. That often means that there is a mismatch between the treatment and the diagnosis. Effective treatment for FND focuses on restoring function. It focuses on trying to move the patient away from focusing too much on the symptom, from trying to use too much conscious control over the symptom, and trying to recruit the normal automatic pathways that they would use without FND. So that implies there are certain physiotherapy techniques that can help with that. There are neuropsychological techniques that can help with that, but they are very much different from the rehabilitation techniques that are used for structural damage, for strokes, for traumatic brain injury, and for all those conditions. There is usually also a psychological component that has to do with avoidance and maladaptive patterns. What that means is whenever someone has a symptom that lasts for a long time, they will start to avoid certain situations like leaving the house, using public transportation. If the symptoms affect their legs, they may become very fearful or afraid of going out or trying to walk again. So all of these things that build up over time need to be untangled when we are trying to work on rehabilitating these patients. That means that input is often multidisciplinary. You should have a neuropsychiatrist overseeing the care and providing a formulation and an explanation of the treatment. It's been demonstrated that just explaining the condition, explaining what functional neurological symptoms are, what FND is, that is therapeutic in and of itself. It often produces a reduction in the symptom frequency and severity. You should treat any comorbid conditions if they are present. And then it usually involves physiotherapy if there are motor symptoms, but again, it's a specific type of physiotherapy, neuropsychological or psychological therapy, and occupational therapy, always looking at function and promoting natural function, as opposed to just trying to replace lost function, which is often the idea when patients have structural damage. In terms of treatment expectations, improvement is often gradual and it's often incomplete. So we are not expecting patients to be completely symptom-free, but we expect the severity, frequency, and functional impact of the symptoms to reduce with time. There may be setbacks, particularly if the patient is exposed to very stressful circumstances. But again, treatment effectiveness depends on the correct model, and that is unfortunately not the case in many cases. Prognosis is therefore very variable. Better outcomes are associated with an early and correct diagnosis, a robust and good explanation of what FND is, shorter symptom duration, and engagement with appropriate disease-matched rehabilitation. Poorer outcomes are seen in longer duration of illness, entrenched illness beliefs, when the patients become convinced that they have some structural neurological condition and they don't accept the diagnosis of FND. When patients are subjected to lots of investigations and assessments, that usually makes them more focused on the symptoms and makes things worse. Or when they are under inappropriate or not diagnosis-matched rehabilitation pathways. Just to give you some numbers, usually 30 to 40% of patients show meaningful improvement with appropriate treatment, 30 to 40% show partial improvement, 20 to 30% show little to no improvement, even with the best of treatments. It sort of depends on what type of FND you have. The motor FND, the one that involves, for example, moving your limbs or walking, usually have better outcomes with appropriate treatment. Non-epileptic seizures also have 40 to 60% response rate with appropriate treatment. Cognitive cases usually have a poorer prognosis. I mentioned before that the litigation process itself can prolong the symptoms as well, not often because of the stress involved in litigation, but also because the process of litigation, for example, seeing a lot of experts who ask you a lot of questions about the symptoms, you tend to, again, focus a lot on the symptoms, and that means that your FND will probably become more difficult to treat. And while the litigation process is going on, until everything is set in place, it often means that the correct treatment is delayed. The NHS provision is unfortunately poor. So these patients will often be left either with no treatment or with inappropriate treatment for many, many years, which of course worsens the prognosis. Now, being mindful of time, I will try to blitz through the case just to put everything in context. So this is a medico-legal case I worked on. Middle-aged male, previously very high-functioning individual, no pre-morbid neuropsychiatric or psychiatric history whatsoever, never seen a psychiatrist, never took an antidepressant, no issues at all. And then he developed ear pain that did not go away. He went to his doctor. A brain scan was done that was unfortunately incorrectly reported, and this was the clinical negligence, which meant that a diagnosis of cholesteatoma was delayed. So cholesteatoma is a benign growth in the ear, but sometimes when it grows to a certain size, it needs to be removed because it starts to cause symptoms, impacts balance, earaches, etc. So there was a negligence, and that resulted in a delay in diagnosis and the treatment. And the consequence of that delay was not anything to do with ear function at the end of the day, because the surgery that was done after the delay would have had the same outcomes as if it had been done before. What was the issue was that the delay caused a prolonged period of uncertainty, stress, pain, and a lot of health worry. That was the consequence of the negligence. Now, what happened after the surgery? So the claimant eventually had surgery. It went well. The cholesteatoma was removed. Everyone was happy with the outcome, but the patient continued to have symptoms: progressive facial pain, spasms, episodes of collapse, and seizure-like events, cognitive complaints, fatigue that did not go away with the surgery. They actually got worse after the successful surgery. And during this period, he was going in and out of hospital, going to his doctor, a lot of misdiagnoses. They thought it could have been a stroke. They thought it could be epilepsy. At some point, he was told that's all due to anxiety, it's all in your mind. So everyone talking about all of these potential diagnoses, all the investigations coming back normal, lots of hospital admissions, a lot of positive signs showing that this was functional. For example, he had an EEG done during a seizure-like event that did not show any seizure-like activity. That is a positive sign for non-epileptic seizures. Otherwise, all the tests were normal, and he was given repeated reassurances that all the tests are normal, you must be fine, but no one diagnosed him with FND. No one explained to him what that was. The closest thing that he had to a positive diagnosis was this is all due to anxiety, which is obviously not very helpful. So by the time I came in, my formulation was that this is a functional neurological disorder, and it encompasses the following symptoms. There's non-epileptic seizures, functional cognitive disorder, and functional pain, and the causation can be understood as an interaction of the following factors. There was some predisposing vulnerability. He had a history of adverse childhood experiences, trauma, and he was also a perfectionist, which amplifies this because these are usually people who self-monitor a lot and they have high expectations of themselves. There were the precipitating factors of the prolonged pain, the stress, and diagnostic delay that was caused by the negligence, and perpetuating factors after the surgery included the disability. He lost his job, and that had a huge impact on him. There was a lack of an explanation, ongoing uncertainty, the litigation process itself contributing to prolonging the symptoms. My opinion was that the index events and the consequences of the negligence were trigger factors for the FND. There was no evidence whatsoever of malingering or of a factitious disorder, and I reasoned why in my report. And he was having input from rehabilitation specialists that was mismatched to the diagnosis, because no one had made the diagnosis, and he was still receiving treatments that were more suitable for structural problems, for brain injury, which he did not have at all. My recommendation was that he should have access to a treating neuropsychiatrist, metacognitive therapy for the cognitive disorder, FND informed CBT for his non-epileptic seizures, which is the recommended approach, and pain-informed psychological therapy. The expectation with this treatment would be that there would be a reduction in the frequency of the seizures and their severity, cognitive efficiency and confidence would improve, and fatigue and pain might persist but become less disabling. So the key messages for you to take home after this rather prolonged presentation: functional symptoms are very real, they are completely involuntary, and they are disabling. Inconsistency is expected. It is a diagnostic feature. It's not evidence of dishonesty. Again, careful with the interpretation of symptom validity tests in this population. Causation is often complex and multifactorial. Index events, injuries often act as triggers, but they are not usually the sole contributors. Effective treatment is available, but there is often treatment mismatch unless the diagnosis is correct. And the prognosis is variable and conditional on the treatment, but there is a real prospect that these patients may improve with the correct treatment. And thank you very much for your attention.
Thank you very much, Dr. Silva. That was extremely interesting, and we already have a couple of questions which we may ask, but actually one myself which I wanted to ask before we jump to the questions is, if solicitors were looking to try and maximize the evidential value of your report in functional presentations, what changes, if any, to their instruction approach might you recommend?
So usually by the time I am asked to comment on these cases, the most important thing to have beforehand is a cohesive and coherent neurological or neurosurgical or all the other physical illness experts need to have come in before and to provide their opinion to say that the symptoms that we are observing in this patient do not match any structural illness, or they are in excess of what I would expect to see with the physical injury that this patient objectively has. So one way to improve the instruction will be to make sure that all that evidence is in place and that all of those features have been well described by the relevant expert, so that then I can come in and I can say that, well, there is positive evidence of the mismatch between the symptoms and any structural evidence, and then I can make that vulnerability trigger maintaining factor formulation based on my neuropsychiatric expertise, and then I can recommend the appropriate treatment for those patients. So my take-home message would be, make sure that all that evidence is already in place and all the other experts are providing a coherent and cohesive formulation from the physical side of things.
Thank you. And we have another question here from Daniel Tobkin. Can a trajectory of FND presentation change as a result of trauma?
Of trauma? Absolutely. So trauma in FND can actually be all three of the vulnerability, triggering, and maintaining factors. So the most common presentation is trauma acting as a vulnerability factor. So like I said before, looking at the statistics and the available evidence, if you ask patients with FND if they have ever had a traumatic experience, many of them will say, yes, I have. So it's usually something that happened before in the past that seems to make them more vulnerable to developing FND later on. It can also act as a trigger event, someone who has a very traumatic experience and then quickly after that traumatic experience develops functional symptoms. It's not a vulnerability there, it's a trigger. And then it can also be a perpetuating factor. If someone has recent trauma that has not been resolved, either through treatment or through the passage of time, if they have ongoing PTSD, for example, that in itself can be a maintaining factor for FND. So the treatment of FND would then include treatment of the ongoing PTSD. So trauma can interfere with the presentation of FND in these three ways. More commonly, I would say it's a vulnerability.
Thank you very much. And just before I jump onto the current last question I have from Khurram Hussain, I just want to tell all of our viewers that this is the first half, and a fantastic half it was, of our two-part psych series happening this month. And on the 18th of Feb, we'll be hosting both a live and an online session in conjunction with Park Lane Plowden Chambers in Leeds, where Dr. Nigel Colbert, a paediatric neuropsychologist, will be joined by the barrister Hilton Armstrong for a discussion on neuropsychological evidence in children and paediatric brain injury claims. So please do join us for that. Khurram Hussain has asked, thank you. First of all, he's thanked you for the talk. Is having ocular-related symptoms an early sign of FND? And if so, how should patients be managed once they have those symptoms?
So visual dysfunction is actually a very rare presentation of FND, perhaps one of the rarest. Although there are a few cases, I've had a view myself, where patients develop functional blindness. They just go completely blind, or sometimes they can see movement, but they can't have, very accurate vision. But it is perfectly possible to have functional visual symptoms. They are rare. However, a good ophthalmologist will be able to show positive signs of functional blindness. So there are a few tests that an ophthalmologist can deploy that will demonstrate the functional nature of the blindness, in the same way that I explained those more neurological tests for the motor, for the motor symptoms, the tremor, etc. There are such tests for visual impairment. So if the ophthalmologist carries out those tests, and if he demonstrates that there are positive signs of functional visual impairment, then that can be a functional disorder. And then again, the neuropsychiatrist will be able to formulate that into a diagnosis of functional disorder manifesting as visual impairment. But it's perfectly possible to have functional visual impairment, yes.
Thank you very much. We've actually received a couple more questions. So with your permission, I will ask. Abigail Bolton has asked, how long after symptoms are first reported would you expect it to take for FND to be formally diagnosed and then for effective treatment to be initiated?
It's an excellent question, but unfortunately my answer will not be excellent, because the sad state of affairs is that the NHS diagnosis delay, and delay in initiating the appropriate treatment is the norm, is not the exception. So I am part of an FND service here in Birmingham. It often takes us at least 1 year to be able to see a patient from the point that they are referred. Before they are even referred, they usually have been going to hospital appointments, doing a lot of tests, being reassured that nothing is wrong for many years before that referral. So I would say it's not uncommon at all for me to see a patient for the first time in my FND clinic who has had symptoms for 3, 4, 5 years before someone realizes that this could be FND, and then they send them to the right place.
Thank you very much. And just lastly, Gerant Harris has asked, does somatoform fall within FND?
Fantastic question again. So I purposefully did not put that in the presentation because I was already worried about time and extent. So somatoform disorder is a bit different. Somatoform disorder implies someone who presents with many different symptoms. Again, in FND, patients often complain of 1 or 2 symptoms that are always the same. It's the arm that does not move. It's the memory problems, the seizures. So it's often a very constant, very single presentation. Somatoform disorder is usually someone who complains of a lot of different symptoms in different systems. abdominal pain, headaches, a tremor, palpitations, difficulty breathing. So you have a lot of symptoms. The symptoms themselves are not particularly prominent, but it's the patient's reaction to the symptoms that is the issue. They become very anxious, very worried about the symptoms, and then they start engaging a lot in asking for tests and going to their doctors complaining of the symptoms. They are often not satisfied with the explanations that they are given, and they become increasingly worried about their health as a result. So this is a bit different from FND, where the main issue is usually a very well-defined symptom that presents consistently over time, and that mimics a neurological presentation. Now, they can coexist, but usually they are easy to tell apart if you look for these diagnostic clues. So different presentations.
I was going to say, it sounds like that's a webinar in itself, perhaps for the future. Definitely. Well, just lastly, there's a lot of thank yous coming in, and I really want to thank you again, Dr. Silva, for a really wonderful presentation today on behalf of myself and at INNEG, and obviously all of our people here. There's a lot of responses coming in to thank you about how interesting it's been. So we really appreciate your time. And to everyone here, thank you for attending, and we look forward to seeing you at our next event.